Vaccinations. As an integral part of United Way of the Mid-South, Women United fights for the health, education, and financial stability of every person in every community. We are committed to helping low-income women and their families thrive. Through giving, volunteering, advocating, and networking, our leaders advance United Way's mission to break the cycle of generational poverty and create meaningful change throughout the Mid-South. Women United comes together for one purpose: to address the critical issues women and children face in our communities. Today, those issues have intensified with the onset of the global pandemic. You see, as women, we love hard. We want the very best for our loved ones. The virus lit a fire in women across this nation and increased our sense of urgency to overcome health disparities. To those women on the front lines risking their lives, to those women who are working full-time jobs and managing virtual school, to those women that are helping family members survive this virus, and those that are grieving the loss because of this virus, Women United stands with you. We are forging ahead in partnership with the United Way of the Mid-South to remove barriers and create pathways to success. To take us further into our program, please welcome one of Women United's leading ladies and Global Women United Leadership Council members, Reverend Marilyn Robinson.
We are so excited to have you join with us at our virtual COVID-19 Town Hall, a time for a candid conversation about the virus, the vaccine, and vaccinations. Women United decided to offer this unique opportunity to our community because we care. We've heard too many of our friends and families express reluctance about getting vaccinated. We've seen too many friends and family die, suffer the loss of a loved one because of COVID-19. So we're offering an extraordinary panel of experts, national, state, and local, to honestly address the issues so we can dispel the myths, the rumors, and the falsehoods that are plaguing our community. To be honest, there have been too many unnecessary deaths, and now we have an opportunity to do something about it. We have 3 goals tonight. We want to inform, encourage, and inspire. You'll leave this session with information about the vaccine and the issues surrounding it. Then we hope that you will be encouraged to get vaccinated. And thirdly, we want you to be inspired to encourage others, and we want others to be inspired by your encouragement and example. We do want to thank our sponsors this evening who helped us spread the word about this event. Local 24 TV, MLK 50 Justice Through Journalism, The Commercial Appeal, and of course, United Way of the Mid-South. It's my pleasure to introduce the presenter for the evening, Dr. Barney Graham. He was recently featured on the front page of USA Today for his role in creating one of the first COVID-19 vaccines. Dr. Graham is the Deputy Director of the NIH. He is over the Vaccine Research Center and Chief of the Viral Pathogenesis Laboratory. Following the initial conversation between Dr. Graham and our moderator, Wendy Thomas, we will introduce our panelists. Let me say a word about Wendy Thomas, our moderator. She's the founder, editor, and publisher of MLK 50, Justice Through Journalism, a nonprofit newsroom in Memphis focused on poverty, power, and public policy. She's also a fellow with ProPublica, a national investigative journalism outlet. Wendy's known for her journalistic integrity, her commitment to getting your answers for questions that you have, and making sure that the public is properly informed. She is a phenomenal woman and a phenomenal journalist. Before we start our conversation, let me just say a word. When we made the decision to have our panelists on stage, we consulted with the Shelby County Health Department and referred to CDC guidelines. You will notice that our panelists are all wearing masks, except when they're speaking. They are absolutely socially distanced, more than 6 feet apart, and there is adequate ventilation in this place. So, as we begin our conversation, let's get ready for a real conversation about the vaccine, vaccinations, and you. Thank you.
Good evening. We will be talking with Dr. Barney Graham, who is uniquely qualified to speak to the vaccine and is really going to go through a lot of the concerns and address a lot of the questions that I've heard from the community and that we collectively have heard from the community. So it's a wonderful opportunity to get information from someone who is, there's probably few people better in the country to talk to about this than him. Dr. Graham, are you with us? Dr. Graham, can you hear us? We've got him on screen. We're going to work out our audio issues. Dr. Graham? You can see his face, just waiting to hear from him. Let me get some. Thank y'all for bearing with us as we sort this out. Okay, so we're going to come back to Dr. Graham in just a moment, and we're going to switch to our panelists here today. And we're going to have Sharika Rhymes introduce them for us.
Good evening. My name is Sharika Hines, and I am proud to stand with Women United of United Way of the Mid-South to bring you this fact-based discussion with medical experts and community leaders. We have with us this evening Dr. Lisa Percy, the Commissioner for the Tennessee Department of Health, who works closely with Governor Bill Lee. In this role, she is responsible for managing the state's response to this global pandemic. Dr. Piercy is a board-certified pediatric physician and former medical director. In addition to her work, she also serves as an advocate against child abuse.
We also have with us Dr. Elisa Haushalter, who is originally from Pittsburgh, Pennsylvania, and began her medical journey in Nashville, Tennessee. She was appointed as the director of the Shelby County Health Department in 2016 by Mayor Mark Luttrell. She brings more than 30 years of experience to her role, having led an array of public health programs and initiatives. She leads the Memphis-Shelby County COVID-19 Joint Task Force with Mayor Lee Harris. We also have with us Pastor Keith Norman. He is the senior pastor of First Baptist Church Broad and the VP of Government Relations for Baptist Memorial Healthcare. He serves on the board of the NAACP of Trustees. And as a vested advocate for the community, he serves on the Memphis-Shelby County COVID-19 Joint Task Force. We also have with us Dr. LaTanya B. Washington. She is the president of the Bluff City Medical Society. She is board certified in internal medicine and pediatrics. Dr. Washington is a physician advisor at St. Francis Hospital and maintains clinical privileges at Methodist Le Bonheur Hospital. She is passionate about improving health inequities through diversity, health literacy, and access. It is with this passion that she currently serves on the Memphis-Shelby County COVID-19 Joint Task Force. Also joining us is Dr. Nathaniel Boutte, referred to as Dr. Nate by his patients. He is a pharmacist for Walgreens Corporation. For over a decade, Dr. Nate has worked closely with patients in the Memphis community to improve health literacy and empower patients to act as their own health advocates. Dr. Nate is particularly passionate about making medicine make sense, as well as mentoring the next generation of pharmacists to provide patient-centric care. And our moderator is Wendy C. Thomas. Again, she's the founder, editor, and publisher of MLK 50, Justice Through Journalism. Wendy is also a fellow with ProPublica, a national investigative journalism outlet. Wendy is known for her journalistic integrity, commitment to getting your questions answered, and making sure the public is properly informed. I'd like to call her the Soledad of the South. Without further ado, let's get this conversation. Wendy, the floor is yours.
Thank you, Sharika. This is quite an honor and privilege to be with these guests tonight and to have Dr. Piercy with us remotely. There's been a lot of news this week, late last week, about the COVID vaccine and the distribution here in Shelby County. So as a journalist, I would be remiss if I didn't direct the first questions to Dr. Haushalter. The state has just stripped the Shelby County Health Department of its responsibility for vaccine distribution. It's been discovered that there were 2,400 expired doses, but that was not the only problem that there's been with the vaccine rollout. There were issues with online registrations being available days before phone registrations, which meant that people who had online access were able to grab all those appointments before people without internet access could. And there were issues with the health department failing to verify that people had appointments when they showed up to the vaccination site, and that allowed people who were currently ineligible for the vaccine to come in. At the commodity site, where it was designed to reach elderly and poor patients, or residents, there were people who were neither poor nor elderly showing up at those sites to be vaccinated. The city council may vote to have you removed from office. That would be just a symbolic vote. But my question is, how do you decide when your presence at the helm of the department is more of a distraction than a help?
Good evening, everyone, and thank you for having me, and thank you for the question, Wendy. It is a relevant question. A few key comments, and then I'll answer your questions specifically. Just want to remind everyone that this is a global pandemic that none of us have faced in our lifetime. And it is, particularly with the vaccine distribution, much like building a ship at sea. During a storm, with lightning and everything else happening. So there are, along the way, unfortunately, errors that get made and lessons learned. As a leader, my responsibility is first and foremost to identify those errors, elevate those in a transparent way, and work with others to correct them so that we can better serve this community. As far as whether leadership is a distraction or it is an addition, really is a conversation generally between myself as well as the mayor. But I'm committed to this community. I'm committed to correcting any of the errors that occur along the way or any of the items that get in the way of access for all. And I would just end with, there are many partners at the table in the Joint Task Force, and I would say each of us in some way has learned through this experience, one, leadership, but also the importance of quality improvement in practice and to be transparent when there are challenges. Thank you.
So the state has decided to give the responsibility for vaccine distribution to the city of Memphis, which was running the Appling site that a lot of people have said was running a lot more smoothly than some of the other sites. Should you have asked for the city's help sooner?
I apologize, I didn't hear the very end of the question.
Should you have asked for the city's help sooner?
Well, we have actually partnered with the city from the very beginning. Many of the sites are multiple partnerships, not just one. So the example I'll use is the Appling site. It's actually run by University Clinical Health, and the city of Memphis provides the property as well as the exterior, like police and law enforcement. The Pipkin site is the health department, previously the sheriff's department, and then also the city of Memphis property. So each of the sites is a little bit unique, but each of them have multiple partners, and each of them has strengths and weaknesses. We enjoy working with the city. We worked very diligently this week to transition vaccine to them and to assist them in their efforts to distribute to our community.
So kind of a follow-up question to that. If it's been a partnership all along, and there are various people playing different roles, why do you think the state took away the county's responsibility for the distribution? Do you agree with that decision?
We worked cooperatively with the state to identify what was the best strategy locally. We're in agreement that for the time being, to move distribution to another facility was most ideal, particularly to another pharmacy. And those vaccines will actually be stored at Regional 1 and then be distributed by the city. So we support that decision, and we'll continue to work with both the city as well as the Tennessee Department of Health.
Okay, so I want to pivot to a question about equity, which is something that my publication has written about, and trying to make sure that people of color, Black people specifically, have had equal access to get the vaccination. As the health department's own data shows that even though white residents are a minority of the Shelby County's residents, they make up the majority of the vaccine recipients. That seems to suggest that whatever kind of outreach efforts that the Shelby County Health Department had are insufficient. I know that there have been some vaccination sites that have been opened in predominantly Black communities, but of course that does not guarantee that the people waiting in line or who have got the appointments are Black people from those neighborhoods. And so I want you to talk to me about what would you have done differently to make sure that the vaccine recipients more closely match the racial diversity of Shelby County's population?
So I'll start with a little bit of a twist on that and then get to the question. First and foremost, we can always continue to improve equity, and one of the ways to do that is to actually be in the community. The very high throughput pods are nice because you can do 1,000 or 1,500 vaccines a day, but they're not easily accessible for people without transportation. So having more sites in communities with smaller throughput, I think, would be particularly beneficial. But the other thing that I want to point out about inequities that's probably not as evident in the data is that at the beginning of the pandemic and the vaccine response, First responders were the first to be vaccinated, medical providers, nurses, and so on. So I also think that it's critical that we look at those disciplines and recognize that there's underrepresentation of people of color in those disciplines. So it's that broader concept of a pandemic within a pandemic and the historic racism that occurs and people being underrepresented in key disciplines. As we move forward through the various phases and with different age categories, what we are seeing is an increased number of African Americans beginning to be vaccinated. And then I'll end with a comment that was actually shared by a colleague that I think is very germane. If we know in Shelby County that people of color have a lower life expectancy than Caucasians, then we should have begun statewide with a lower age, particularly 60 or 65. We also know that our deaths locally are more likely in people over 55. We could have even started as low as 55 to make sure that people of color who were most at risk actually had access.
That is an excellent point that I will bring up with Dr. Piercy in just a minute. We've got Dr. Graham now with us. Dr. Graham, can you hear me? I can see his mouth moving, so I'm going to assume that yes, he can hear me. And we're going to go back to some questions that we have for you. So I want you to explain to us as briefly as you can, but as comprehensive as it needs to be, the process used to develop the vaccine. I'm not sure if the question is, if you can hear our question. We may have to pivot back to the panel. Okay, so we'll keep going. Do we have Dr. Piercy with us? Okay, so Pastor Norman, actually I think we're going to go to Dr. Washington next. You're out in the community, you're leading an association of physicians that are well aware of the significant health challenges in the African American community. So I want you to talk to us a little bit about what you're hearing from your patients about their willingness to take the vaccine and maybe even some of their concerns.
Well, the one thing that a lot of patients are talking about is that they really have concerns regarding how quickly the vaccine was developed. And so that's their main concern. They want to make sure that it is safe. And so certainly for us with the Bluff City Medical Society, we have started a robust public education campaign where we are willing to provide information to the citizens of Memphis and really across the country using our social media platforms to talk about COVID-19, to talk about what the disease is, to talk about what COVID-19 can do in acute infections, but also to talk about what COVID-19 can do for the long term, and then also to talk about the COVID vaccination. One of the things that a lot of people have seen on social media and on the Bluff City Medical Society website is that a lot of our physicians have already received both doses of the vaccine. And so I don't want to make it look like we were only receiving the vaccine, because while that is important, it's also important that we let the community know that the vaccine is safe. I personally have received both doses of the vaccine. I supported my family members. I have siblings who are in healthcare and they received the vaccines. And my mother is elderly and she's also received the vaccine. And so just to lead by example has been one of the most important things. And I've received feedback from many people in the community that have said, you know, the way that you represented things about COVID-19, the way that you talked about it and made it more realistic was one of the reasons why I began to take it seriously. I watched what I did going out and about. I made sure to wear the mask. And I was initially afraid of receiving the vaccine. However, your chronicle of that you received the vaccine and talking about it has made me more comfortable with receiving the vaccine. And that's really our primary goal.
Absolutely. So let me ask you, Dr. Washington, as the vaccine was being developed, were you initially like, yes, I'm going to be first in line? Or were you even like, let's see how this goes. Tell me about your process.
Well, I will say that initially when I heard about the COVID vaccine development, I was thinking, oh, it's going to be a couple of years before we get a vaccine. So that was my initial thought. And to see that the vaccine development was so quick, of course, it was very encouraging. Did I have some questions? Absolutely. So what I did was, once the primary data was available, I looked at it myself. And once I saw that, it was very protective for patients that were included in the study and really reduced hospitalizations and deaths, I said, oh, sign me up. I certainly will be at the front of the line. Because even when I heard initially about COVID-19, when it was really only a disease that we were hearing about in China, I knew that if that got to the U.S. shores, that we were going to be in big trouble.
That's helpful. Dr. Haushalter, I want to pivot back to you. If you could speak, if in the interim before we get Dr. Graham on board, when people say this vaccine was developed too quickly, there's no way they could get this together in less than a year. What's your response to that?
Even though it was completed within a year, it had to go through all of the typical processes for approval before it was approved for safe use in the community. So I feel confident in the fact that it was completed through the general processes that we know need to be done. And then also I agree with the comments that were made that it's important to role model as well. And so I am also vaccinated and try to share that with others so they feel more comfortable.
Speaking of role models, that takes me to Pastor Norman. As it's been said, you're a pastor, you're an executive at a hospital, you're a member of the COVID task force, and you're interacting probably with more people in the community, certainly than I am, on a day-to-day basis. And so tell me, one of our activities that was dramatically curtailed during the pandemic is church attendance, right? That was discouraged. So talk to me about how your church dealt with that, and then also what you've told other pastors who are grappling with whether to have service in person or do it virtually.
Well, thank you for the question. Immediately on the first day, as a matter of fact, Dr. Haushalter and I met at the health department, and we knew that this meant that church services would be disbanded. I reached out to my colleagues in a very large circle here in Memphis and began to explain to them everything that I understood, both from the healthcare perspective and what this meant to large congregations, especially gatherings of a public nature, while also recognizing the social implications of how African American people especially receive information. I knew that we would have to build systems of communication to reach out to our parishioners. And so our virtual services took on more than just the nature of worship, but they really became information formats where we would take the information from the health department. Oftentimes I would have Dr. Bruce Randolph and others to come to our church, come to our Bible study, and to share with people what was actually going on. Remember that we knew our congregation demographically very well. We understood that some of the elderly members would not have Wi-Fi and computer use, and so we had to make sure that we would set up engagement opportunities. And so we put ambassadors together in our congregation who had the responsibility of calling 50 to 100 people each and making sure that they were okay, getting information to them, and helping them to understand what was actually going on. We continue to use that system today. It has been effective. However, in communities right now, we're taking that same opportunity to inform people about the vaccine. Since that's why we're here and this is where we're headed to some degree, we realize that information is extremely important because of the history of things that have taken place in this country. We don't deny those things, but we don't highlight them in a way that they take the headline. We realize that in order to gather again and in order for us to return to some sense of normality in the United States, we will need to inform people and allow them to become, as Dr. Boutte says, your own personal advocate and get that information. So we use the church platform for that and make sure that we get it done. Virtual worship is still going on, and we're looking for ways to re-engage at a greater level.
So we're in a church, but are you saying that you can worship outside of a church. God can be present somewhere,
Of course.
somewhere else.
Our theme is bringing God's house into your house. And of course, you can worship wherever you are. As a matter of fact, statistics point to the fact that over 48% of churches in America have improved in their contact and their support. People are still being very faithful. Barna Research points that out, that churches that are working in that area, they're doing very good. Smaller churches have suffered to some degree because they may or may not have had all of the digital platforms needed. But thankfully, even here in Shelby County, the mayor went out and made grants available for small churches to be technically savvy. We've loaned our platform to others so that they could come in as well if they chose to. And then we've helped to educate how they could get their message out to the general population.
Well, that makes sense. I know that I've talked to people and I've asked them, you know, so are you going to get the vaccine? And they're like, no, I'm trusting God. You know, if I get sick, it must be God's will. I'll just accept that. So what's your response to that? I'm going to trust God. I don't need a vaccine.
Well, first of all, we trust God in everything that we do, whether we recognize it or not. When you get up in the morning and put your feet on the ground, you're trusting God that it's there. And so information is extremely important. I think one of the things that has happened is that oftentimes we've rushed past the reality of why people had hesitancy. And to address those realities and to affirm their reality is important. And then to offer information and time to go forward. I also agree with my colleagues here on the platform that none of us probably started out 100% ready to take a vaccine. We have moved gradually as we do in our faith. Faith cometh by hearing. It continues to come, it continues to grow. And the more we learn and hear about the efficacy of the vaccines, and then we see evidence of people taking the vaccine, we become more trustworthy. I'm a fully vaccinated person. I'm healthy, I'm well, no side effects. I encourage it, but I don't rush people to go get it without taking their time to pray about it. So I would encourage the person to pray, but then take the vaccine.
Right, I get that. I think that's really important what you said about people needing to move forward in their own time. And if you look at some of the vaccine attitude polls that have been done nationally, you know, I think a lot have been made about vaccine hesitancy among Black people. But I think that word is important, hesitancy. It's not, no, I will never. It's let me wait and see. And every day that passes feels like that's another day that we're waiting and seeing.
I believe, has been misinformation. We started out with a pandemic that was, first of all, the national leadership was in denial of it. And so we get misinformation, and then we start curtailing or changing the narrative as we go. And what we want to do is try to be as clear and concise as possible as we update information and keep people informed and be transparent.
Dr. Nate, I want to turn to you. The vaccine is now being distributed at pharmacies. So not the pharmacy you work at yet, Walgreens, but at Walmarts across the region. And so you have contact with people coming in, trying to get their prescriptions. What are you hearing from them about the vaccine?
So thanks for having me tonight. As my colleagues have all said, there's a concern about the safety of the vaccine. You mentioned the word hesitancy. Even in my pharmacy, so I have about 15 technicians that work with me as well as other pharmacists. And when I mentioned that we're eligible, we can go out and get the vaccine, I had a couple of So I said, if anyone has any questions, they're on the fence about the vaccine, come and see me. And just like the patients, they just have questions like, was it developed too quickly? Can you explain to me how they developed it so quickly? Is it safe? Is it effective? And like Dr. Washington said, we looked at the information, we looked at the data. We looked at the science, and the science said, yes, it was developed quickly, but there's a reason for that. And we have the reasons, and we know why it was developed quickly, and we're able to say it is a safe and effective vaccine. So the biggest thing is reassuring people that the vaccine is safe and effective, and I can reassure them because I've had both of my doses as well, and I am encouraging all of my family and friends and my in-laws, for example. My in-laws are in Nashville, and they were very hesitant. Both of them over the age of 65, and I've got a 3-year-old, and I want him to go and visit with them, but I said, hey, so y'all get signed up to get this vaccine, y'all are not gonna see him. So they are signed up to get the vaccine, and hopefully they'll be getting it soon.
Thank you for that. So I'll let whichever of the health professionals on here want to try to take this question. Another one of the questions I've heard in the community is, does the vaccine change your DNA? Dr. Washington?
I can take that question. So the vaccine does not change the DNA. The COVID vaccines that are currently available, the Pfizer and the Moderna vaccine, are messenger RNA vaccines. So nothing is incorporated into your DNA. The vector that is used for the vaccine is injected into your arm, and your body creates an immune response to that vaccine, and then that waste is excreted. So nothing is incorporated into your DNA, and so that's something that's very important.
Okay, so there is no live COVID vaccine, COVID virus that is a part of the vaccine. Is that what you're saying?
Right. None of the vaccines that are available at this time have any live virus. So it is not live virus that is being injected.
Okay. Did you want to add anything to that, Dr. Householder? I see you nodding yes. Yeah. Okay, here's another question. Does the vaccine make you sterile? Is this, I mean, there are a lot of conspiracy theories out there, right? Is this something that's going to be used as a population control tool?
I'll speak on that as well. You know, I think that it is certainly relevant to talk about this, just due to the history of vaccines and experimentation with persons of color in the population. But this vaccine does not affect fertility at all. I will also speak and say that I am a woman of childbearing age. I had no hesitancy when I received my vaccine. A lot of my colleagues as well, they didn't have hesitancy. Many of my colleagues are pregnant right now. They received the vaccine while being pregnant. Also of note is that in the primary data that was released for the vaccine, pregnant women were not enrolled in the study, but several women did become pregnant during the study, and there was no long-term effects to the patient or to the baby.
So that sounds like, from what the data that we have, it is safe. Do you know if there are any plans, anyone, to do trials that include women who are pregnant, or I don't know if that becomes if a woman is pregnant, if they'd want to sign up for that?
Yeah, so that's a huge issue. There's not a lot of experimentation or research studies that incorporate pregnant women, just because the risk is so high if they have an adverse outcome. So there may end up being some studies later on down the line, but currently, to my knowledge, there's no plans for studies in pregnant women.
Okay, so another question that I've heard, or what I've heard people say is a reason why they don't want to get vaccinated, is that there's a chip or some kind of tracking device in the vaccine. I know that, I was raised in the church, and there was always, the talk of the mark of the beast, right? You never want to take the mark of the beast. Is there something in the liquid that's being injected into you that could be used as a tracking device? Like, just plain, is that possible? I see everybody reaching for their mask.
I can start off on that one there. I think what people are hearing is the term new technology, and they're hearing nanoparticle, and they're hearing it in rapid succession. And to me, that sounds like nanotechnology. And, I watch the Marvel movies and everything like that, and you hear that type of stuff all the time. What it is, yes, it's new technology, but a nanoparticle is simply a measurement of size, just like saying a gallon of milk. It's just a very small particle, and this new technology is actually used in some cholesterol medications. Some of the new injectable cholesterol medications, it's just very, very small. That's all it is. There's no actual chips or anything like that at all being injected when you get the vaccine.
I think we've got Dr. Graham. Is he on? Can you hear me, Dr. Graham?
I can hear you. Can you hear me?
I can. Wonderful, wonderful.
Okay.
So
We'll try this again.
We'll try it again. So I wanted you to tell us a little bit about the process to develop the vaccine. We've talked a little bit about the speed. I've heard people say, how could they come up with a COVID vaccine in less than a year? They can't even cure cancer, right? And so can you talk to us about that process?
Yes, first of all, I'm very glad to be here. I appreciate the chance to talk to you all tonight. And this has been a long story. It's not a one-year story. I could tell the 35-year story, but I'll start with 10 years. We've been developing a lot of new technologies as we try to develop a HIV vaccine. I'm deputy director at the Vaccine Research Center at NIH, and it was founded 20 years ago to make an HIV vaccine. Those technologies, we have not solved the HIV problem yet, but it has created a lot of solutions for other unmet needs and even some emerging infections. So we solved the problem of another virus called respiratory syncytial virus in 2013, about the time the MERS coronavirus was circulating in Saudi Arabia. From that time, we applied the learnings we had in RSV to the coronavirus family. And we learned how to see and visualize the spike protein, the surface protein of that virus, in great detail, down less than a nanometer that you just heard about, down to the angstrom level or the atomic level. And so we know exactly what this spike protein looks like, even though it's about 10 million times smaller than your fist. And we also know how to hold it together so that it maintains the right shape, because that's what antibodies see. And since 2017, we've been working with the company Moderna because we knew how to make the right kind of protein for vaccines, and they know how to make something quickly with this mRNA technology because it's synthetic. We've been working for the last 3 years on something called the prototype pathogen approach to pandemic preparedness. So we had already made an mRNA vaccine with the stabilized spike protein of the MERS coronavirus and shown that it could be protective against that MERS challenge in animal models. And we'd also done it with some other virus families. So when this outbreak was announced, we agreed with Moderna, they agreed with us that this would be the time to do our demonstration project and show people how fast we can go if we know what to do ahead of time. And so the day the sequences were released on the 11th of January, the next morning, that Saturday morning, we designed all the reagents we needed, all the assays we needed, how to make the protein, how to make a vaccine. And by the next Tuesday, on the 14th of January, Moderna started manufacturing because we had a trusting relationship, and they trusted that we were making the right protein. And as we went, the vaccine worked in mice, the vaccine worked in monkeys, the vaccine worked in people at the small stages, and as we went up to larger numbers, when we did the experiment in what's called phase 3, the large trial, where 15,000 people get the vaccine and 15,000 people don't get the vaccine, we found that against symptomatic coronavirus disease, it was 95%, 94% effective. And so the numbers broke down like this. There was 196 infections, 185 infections were in the placebo group, and only 11 were in the vaccine group. And in the subgroups, there was also good levels of protection in people over 65, and in people of color, of the 42 infections, 41 were in the placebo group, and only 1 was in the vaccine group. And of the 30 severe cases in which people had low oxygen or had to go to the hospital, all 30 of those were in the placebo group. So this was an extraordinarily effective vaccine, more than we had hoped or even expected. So the story is that it's really a 12-year story or a 20 or 35-year story, depending on how you tell it. And it's not really a one-year story. And I hope people, I'd like to show them some pictures if we have time for that, to try to illustrate some of these ideas and how we knew how to go fast.
Thank you for that. I'm not sure we're going to be able to go to pictures, but what I did want, I kind of want to synthesize what I heard you say. So it sounds like there was already a team that had been practicing together and working together on this kind of technology, this kind of a vaccine. That would be the government and Moderna. And you were already maybe on third base when the COVID virus emerges. And so getting from third base to home did not take you as long as it might have if you were just starting from scratch, didn't have that relationship, weren't already working on this sort of vaccine. Is that accurate?
That's accurate. And then the other thing that changed was the government put a lot of money into this, so it took away the risk of money. Ordinarily, in a vaccine program, you do things serially because you don't want to put your money and time at risk. But in this case, because of the crisis, the government put a lot of money into this, and the companies could operate and only pay attention to safety and efficacy. And so all the different stages of development were compressed and done in parallel. And the data package for this vaccine, for all the vaccines, the Pfizer vaccine, the Moderna vaccine, and the Janssen vaccine, are all extraordinary compared to some of the other vaccines I've seen happen over the last 35 years. So there was no shortcuts here on testing, especially for safety.
Okay, we want to make time to get in Dr. Piercy, but I just want to ask you a couple other questions. Talk to us about variants. I know it seems like every other day we're hearing about a variant that's emerged in a different part of the country, and now maybe even California. I've heard people say, maybe I should wait until they've come up with a vaccine that can deal with the variants before I get vaccinated. What's your thinking on that?
Coronaviruses are RNA viruses. Their genome is RNA, and we know those viruses changed. We know how influenza changes from year to year. 20% of influenza protein on its surface, called the hemagglutinin, can change from year to year, and that makes our vaccines difficult to work. In this case, there's been 9 amino acid changes of the 1,200 or so in the protein, and so a small number of changes have occurred. Some of those do reduce its ability to be blocked or neutralized. The antibodies that we make with the vaccine don't work quite as well, but they work well enough to protect against severe disease very well, and they still work against even mild disease. So I don't think that we're in trouble in terms of needing new vaccines, and the current vaccines will still work. And because of this new technology, it's easy to pivot and to put new sequences into the vaccine. Moderna announced last night that their new sequence based on the South African variant is going to be started in early phase trials, phase 1 trials, in just a couple of weeks. And so that vaccine's already been received at the National Institutes of Health, and those studies will start very soon. So there are changes. The more the virus grows, the more it's going to change and adapt and select new options for itself to be more transmissible. So the thing everyone has to remember is that every time you allow a new infection to occur, you're giving the virus a chance to escape the vaccines and treatments that we've developed.
Okay, so I'm hearing that the vaccine, you should get it now, not wait on something else that might work better, that is still protective against severe disease. I think we think a lot about the deaths, but nobody wants to be hospitalized or end up with serious breathing, respiratory problems because of this. Talk to us a little bit about herd immunity. What is that? Why is that important?
Now here, I think, is where they do want me to share some slides. Okay, here we go. So herd immunity, I really don't like the term because it's a veterinary term. So I prefer to use population immunity or community immunity, because that's really what it is. So I'm illustrating here on the bottom panel that the blue people on top are not immune, and the green people on the bottom have immunity. And so when a virus meets a population without immunity, a lot of people get infected. Those are the red people. And it has a high transmission rate. It's much lower when you have the immunity. So go to the next slide, please. And the problem with high transmission rates and a high force of infection is that you're going to also have more severe disease. And that's what we're having now with a high mortality rate, especially in our older patients and people with other risk factors. And you see in the bottom, the immune population, even though there's infection, the disease is much milder. And the way herd immunity works, or population immunity works, you see the blue couple in the middle on the right lower cluster. It's completely surrounded by immune people. And the red person at the top of that cluster is completely surrounded by immune people. That will break the transmission chain. The red person can no longer infect the blue person. So population immunity means that you are protecting each other, and especially when people have immunocompromised states, if they're on chemotherapy or other things, they may not make a good response to the vaccine, and they would need to be protected by the people around them. So vaccines do two things. They protect the person, especially the lower airway, especially against severe disease and death, and they also protect the community.
Great, that's helpful. I think that visual is very, very helpful. One last question. The Johnson & Johnson vaccine, one shot. Yes, no, great. Are you worried that people will think, well, why am I getting just one shot? Is this somehow inferior? Speak to that.
I think the answer to that is that any vaccine that the FDA approves, and the VRBPAC, their vaccine-related advisory committee, says is safe and effective, then I would be first in line to take that vaccine if it was available to me. And so I would base my judgment on whether to take the vaccine based on the FDA's opinion. And you'll see different numbers for efficacy. The mRNA vaccine had 95% efficacy against moderate disease or mild disease, and almost 100% against severe disease. The Johnson & Johnson may have only 75 or 80% effectiveness against mild disease, but it still has nearly 100% protective against severe disease. So this vaccine, even as a single dose, will have a big benefit. Even the mRNA vaccines, you start to accumulate immunity after the first vaccine. It's just the second vaccine helps to boost that and maybe make it last a little longer. So for now, if the FDA approves this vaccine and it becomes available, I would get in line for it.
Great. Hopefully, being at the NIH, you've already been able to be near the front of the line. I'm hopeful for that.
Well, I've been vaccinated, but unfortunately, my wife has still not been vaccinated, so I'm still working on that myself.
So not everybody gets a hookup. Okay, understand that. Do we have Dr. Piercy with us? I think we'll pivot to her if she's available. There she is. Dr. Piercy, welcome. Got a few questions for you. One of them is, if you leave out the U.S. territories such as Puerto Rico, Virgin Islands, Tennessee is tied with Utah and Georgia for last place based on the number of vaccine first doses given. Even when it comes to second doses given, it's still near the bottom. Why?
Yeah, thanks for having me, Wendy, and the entire group. This is a very distinguished panel, and some of them are personal friends, and so it's a real honor to be with you tonight. So you're exactly right. We have fallen pretty low on the list in first doses. There are a lot of reasons for that. Part of it is a product of our own early success. We came out of the gate really quickly on first doses, and we're one of the national leaders in second doses. And so we dropped off in first doses, but that's not the whole story. There is a well-known trade-off in equity and speed. In fact, there was an op-ed in the Washington Post, I think it was a couple of weekends ago now, talking about that very phenomenon, in so much as when you get it to populations who are most vulnerable, you by necessity have to slow down. And you will remember that our plan has been lauded nationally on multiple occasions and by many different entities, both in the former presidential administration as well as the Boston Globe and MIT, Harvard, the School of Public Health, as being one of the most equitable plans in the nation. So part of me is really disappointed in that ranking, but part of me understands why, and I'm very, very proud of our focus on equity. I will just kind of level set, though, in overall doses. It's been a couple of days since I've looked at it, but last time I looked, we were number 20 overall in the nation in total doses administered. When you look, I believe we're the 16th or 17th most populated state, so that's pretty consistent. We now have about an equal number of people that have had first doses and second doses, over 800,000, and right at almost 11.6% of our population immunized. So we're getting there. Equity is one of the reasons that we're going slower, because we want to get it to the people who need it the most.
Right. I've got my reporter, hopefully she's listening. We'll fact check that, make sure that's accurate. So you mentioned the state's plan and its focus on equity. And I think that's interesting because if you actually read the plan, the word African American or Black doesn't mention once, right? So it doesn't come up once. They talk about vulnerable populations, socially disadvantaged, but as we know, that can often leave out Black people because of the failure to be explicit. Black residents make up 17% of the state population and only 7% of vaccine recipients. Help me square that with what you just said about the most equitable plan that's been lauded by the president. This was the prior administration, and then also Boston Globe. Help me square that.
Sure. Equity means getting to all of the communities in an equitable fashion. So let me tell you what equity does not look like. Equity does not look like only having vaccine in multiple mass vaccination sites where people can't get there, particularly in a very widespread and sparse, often rural geography in Tennessee. Having mass vaccination centers in a few of our larger cities does nothing for an equitable allocation geographically. You also have equitable allocation in communities of color, just as you mentioned. One of the highlights of our plan that has been most highly lauded is our social vulnerability index. This takes into factors such as race and income, as well as socioeconomic status of the zip code and even down to the block. It is a nationally produced index that shows us where our most vulnerable spots in Tennessee are. We are one of the only plans in the nation that actually prioritizes allocation into those zip codes and even down to the block level in some instances to get to those that are most socially vulnerable. Again, not only for race, but also geography and then age. We also prioritize those, as you've seen in our plan, those who are at most risk based on their age. We know that in Tennessee, it's the same probably across the nation, but certainly we're concerned about Tennessee data here. Over half of our hospitalizations and 80% of our deaths come from our elderly population of all colors. And so that's why you've seen a very strong focus on elderly population in our plan, because we know those are the most vulnerable. We have seen a drastic decrease in both hospitalizations and death amongst the elderly, amongst all Tennesseans, but specifically amongst the elderly. And we know that that is in large part due to these vaccination efforts of the elderly being prioritized.
So when you speak about the social vulnerability index, that's the index established by the state. And I believe, if I remember correctly, the state was going to allocate 5% of total doses to communities where that index was particularly high, and I believe there were 35 counties. Shelby County was one of 35. I've asked the state this before, and I'm hoping that if you don't know the number, you can make sure that's available. How many doses, hard numbers, went to Shelby County because of that social vulnerability index?
So I want to clarify that the Social Vulnerability Index is calculated by the CDC and is available to all states. It's not Tennessee specific. We are one of the few states that actually paid attention to it and made allocation decisions based on that, but that's not a state metric, it's a CDC metric. The 5% is in addition to the regular population-based allocation. I'm happy to get you the exact number for Shelby County. It's around, I believe, 100 and I'm hesitant to say it off the top of my head, plus or minus 150,000 doses that have been sent so far. That actually may be a little bit more than that because I know Shelby County has administered about 121,000 doses. I just looked at that number earlier. And then they got an additional 5% more than other counties because of that SBI.
Okay, I'll follow up with Mr. Christian on some of these specific details. You spoke just a second ago about getting the vaccine to the people who were most vulnerable and those being elderly. One of the things that Dr. Haushalter raised before you joined us is that we know, data shows, that Black people are getting infected and dying of the disease at ages, on average, a decade younger than white people. And so if equity is a concern, talk to me about the decision not to adjust the age threshold in some way to account for the fact that Black people are dying at younger ages of the disease. Because that was a decision, as I understand it, and I want to understand how you made that decision.
Sure. So I was able to hear Dr. Haushalter's comments on that, and she made some very good points. I want to explain to you how our prioritization decisions were made. We have a pandemic vaccine stakeholder group. It's about 38 or 40 folks, the vast majority of whom are outside of state government. So people from all different types of communities, representing different agencies, different associations, and all of our prioritization and our phasing was decided by this group. This was not a state government decision. Her point was well made in so much as, and I'm paraphrasing here, and you can correct me if you think I've summarized it incorrectly, but I believe the point she was trying to make is people of color, their life expectancy is shorter than that of Caucasians. And so therefore, when you prioritize by age, by necessity, there are less people of color because their life expectancies are longer. That is understood. It is also very well documented that the risk is based on age, and our plan is very risk focused. Not only healthcare infrastructure, that's why we prioritize our healthcare workers first, but also those with individual health outcomes or at risk of poor individual health outcomes. Let me be crystal clear. If we had unlimited product, there would be no question of who could get it. Everybody could get it. That's exactly what I would want. But when there is a limited supply and when the demand greatly exceeds the supply, by design, you have to prioritize it. And in our state, it is an age-based prioritization because that is where our hospitalizations and deaths are. Fortunately, as we are now getting down into lower age brackets, we are, and Wendy, you may have made the point, or somebody else may have, that we are starting to see those numbers grow in our communities of color as we get down in lower age. So I continue to see that number grow. That's encouraging to me. We are currently in the 65 plus and 1B or teacher category. And so, we know that communities of color are represented more heavily in those groups. And so we're looking forward to that number continuing to grow.
Okay, so it sounds like to me that, just to kind of reiterate, the plan was risk focused. The state's aware that the life expectancy of Black people is lower. The research also shows they die at younger ages. And still, the threshold was set at 75. Is that correct?
That's right. That's consistent with the ACIP guidelines. So ACIP is the body on immunization practices of the CDC. And you'll remember that that was their initial recommendation to start with 75 plus. And then they recommended you go down to 65 plus. We mirrored that plan. So we started out at 75 plus. Instead of going directly to 65, we went to 70 and then to 65 because we were trying to match the population with supply. So they're consistent with national guidelines, but it was also adopted by our state's stakeholder group.
Right. I actually talked to one of the ACIP members just the other day, interviewed her for a story. The ACIP recommendations were just that. They were recommendations. They weren't binding. And you see in other states that other occupational groups have been prioritized, for example, teachers. So I'm still not quite getting the thinking behind the decision.
Which decision?
The decision to start with 75, what you just said about it being ACIP's recommendations, but understand that those were not binding. Tennessee could have chosen differently, am I correct?
Yes, ma'am, you're correct. Those are recommendations, and we, like much of the nation, followed ACIP's recommendations. You mentioned teachers. Teachers are our highest priority workforce behind healthcare workers in our plan. So there are no other occupations other than healthcare prioritized higher than teachers.
Okay, that's interesting. I think I'll segue back to a question for Dr. Haushalter. I think one of the criticisms from the state recently has been the prioritizing decisions that the Shelby County made to make sure teachers got vaccinations. And I can understand why that happened, particularly because the state, Bill Lee, was threatening to withhold funding from Shelby County schools if they did not return to in-person teaching. So can you talk to me at all, Dr. Haushalter, about how you're balancing these external state pressures with what you know educators here on the ground are needing?
Sure, and just for clarity, our decision to move to teachers was timed with the state's decision. So we have been adherent to the phases of the state plan from the beginning. We had anticipated we could get to teachers around mid-February. However, with feedback from the state health department, they really cautioned us to go a little bit slower and get more of that first phase vaccinated. So then we looked at a date of March 1, and then in the interim, the state opened up to phase 1B, which allowed teachers to begin to be vaccinated, as well as child care workers. And so we quickly worked with Shelby County schools and the municipal schools to begin their vaccine this week. And there are many thousands of vaccines going into teachers' arms this week. So I actually think we were in alignment with the state. We just were, at the beginning, moving a little bit quicker than we probably should have.
Is that something you regret? Because I have to be honest, my sister was one of those teachers who did get a first vaccine, and my family was very worried about her going back to school with no protection to be in person.
As was noted, teachers are not the most highest risk category, and so it's not necessary based on the CDC plan for teachers to be vaccinated prior to getting back to school. However, we do know the teachers' desire to be vaccinated, and so we worked with, again, the state relative to their phases and the schools to begin their vaccines this week. There were 2 pods held during the inclement weather. I think everyone knows we were hit with severe weather that lasted really almost a week. And then we had the water pressure issues. And during that time, we did have some vaccine that needed to be used. And so we worked with Shelby County schools, the municipal schools, and the independent schools to hold 2 small pods. And that was about a week early. But I also did notify the state that we were using the vaccine that way because we did not want it to expire.
Thank you for that. I think we're at the phase of the program where we're going to ask everyone just to give a final thought. What's the takeaway? What do you want the audience to leave here knowing, understanding? We'll start with you, Dr. Nate.
If there's anything that I would like everyone at home, if you haven't picked it up from everything that's going on here and everything that's been said tonight, get signed up, get any vaccine that's available to you as soon as you are eligible. If you're on the fence, we've given you lots of good information. There's more good information out there, but please get signed up, get the vaccine, anyone that's available to you once you're eligible.
Dr. Washington.
I certainly agree with Dr. Nate to get the vaccine that is available to you as soon as it is available. I will also say make sure that you are well educated about what COVID is, what it can do, as well as the long-term effects. Again, we have provided a lot of information about the vaccine. There is a lot of information that is available online, on the local news. Make sure you're using reputable sources and make the decision for yourself. Talk to your personal physician. talk to your friends, family members. If you have received information and your mind has been changed about the vaccine, or if you're feeling more comfortable about the vaccine, make sure you share that with the people in your circle, because by doing so, you are keeping your community safe.
Pastor Norman.
I think that people approach faith in very different aspects and different ways. And so I want to make sure that I'm inclusive in this conversation, that no matter how you approach your faith, make a decision and to take the time to get the information that you need, consult with your family members and your personal health practitioner, and please proceed to get the vaccine if it is available to you. Many of the conversations that we hear circulating today are about the headlines or about the news. We can't fix yesterday. We can have a better outcome tomorrow when we all take advantage of making sure our personal health, our movement towards the group population immunity factor is being met. That's going to take a collective effort of every individual taking personal responsibility and then going forward in that direction. I know there are a lot of conversations about who's on first, who's doing this, or whatever is going on. The most important thing that we can do right now is to make sure that we get the information, make a well-informed, faithful decision, and get the vaccine.
All right, we definitely want to bring in Dr. Piercy and Dr. Graham. So Dr. Piercy, any takeaways?
Thank you again for having me. So what I would remind folks, I would reiterate exactly what my fellow panelists have said. The best vaccine is the first one you can get. And so please do that at the first opportunity you have. But also don't forget, this isn't over yet. It's not a get out of jail free card. You have to continue the precautions until, as Dr. Graham said, our community is immune. That means continuing to watch your distance and wear your mask and wash your hands. I know people get tired of hearing us say that, but it's really important to continue this. This is going to be here for a little while longer, and until we can get our community immune, we have to continue those precautions. And one final encouragement, if you have gotten your vaccine already, help your neighbor, help your family, your church members, your family and friends. Help them get scheduled. Help them arrange for transportation or take them to their appointment, and we can all get through this together.
Thank you for that. Dr. Graham?
Yes, I've heard a lot of good answers already, but I think I'd like people to consider this. Within 3 to 5 years, probably everyone is going to have immunity to this virus at some level. And you're either going to get that through an infection or you're going to get it through a vaccination. The infection has a 1 or 2% mortality, and higher than that if you are older and have risk factors. And but also it has about a 20% chance of long-term side effects. The vaccine has about a 3 to 6 times out of 1 million chance of a severe allergic reaction that can be treated. So to me, that's the fundamental decision. You have to decide, am I going to be infected and take those risks, or I'm going to be vaccinated and take these risks? And one of my greatest concerns that keeps me up at night is that in a situation where we have communities of color that have 3 to 4 times higher hospitalization and mortality rates, that if they have a lower uptake of vaccine than other communities who have less disease, that a year from now, instead of a 3 or 4 times disparity, there's going to be a 6 to 10 times disparity. And that is something I really don't want to see. So this is a community process. Everybody's in this together, not just in this country, but the whole world, because if someone generates that new mutant strain in some other country on the other side of the earth, it can still get back to us. So this is truly a everyone is in this together type of event.
Thank you for that. And we'll turn to our local health official and give her the last word. Dr. Haushalter.
Thank you, Wendy. I echo all the sentiments of the panelists, so I'll just add 2 other remarks. One, be an ambassador, so share the information that you have with others so they can make an informed decision as well. And lastly, really think about volunteering, not only driving someone to get their appointment, but potentially volunteering at a vaccine site. We need many people in this community to make this happen, and so volunteering would help as well. Thank you.
Thank you so much, all of you. I think it's important to stress that the decision is yours on whether to be vaccinated. We just want to make sure you have the right information to make an informed decision, but the decision is yours, and no one can force you to do it, but we want you to be prepared for whatever you decide. I'm looking forward as a community, as a society, to getting to the root of some of the inequalities that COVID has exposed. We knew we had issues with internet access, with transportation, with access to health care, with a predominant Black and brown workforce in jobs that put them at higher risk of exposure, whether that's nursing home assistants or people working in environmental services at hospitals. And so it's my hope that as through this, we can address some of those systemic inequalities that COVID exposed but did not create. And with that, I will turn it back over to Naika Parks for some closing remarks.
Good evening. I am Dr. Naika Parks, and I'm a proud member of Women United of the United Way of the Mid-South. This panel has informed, inspired, and empowered us to make an educated decision about the vaccine. They've answered tough questions candidly and with integrity. Dr. Graham has even educated us about the origins of vaccines, how they work with the human body system, and how they also protect us. He then dispelled several myths. We realized that we couldn't answer all of your questions on tonight, but you can find more information about the COVID-19 vaccine on the CDC's website at www.cdc.gov and on the Shelby County Health Department's website at www.shelby.community. You may also find more information about tonight's panel on the United Way's website, and that website is www.usmidsouth.org. Please continue to check back in the coming days because the rebroadcast of this panel and an FAQ will be posted on the United Way's website. Feel free to share information with others who may have missed tonight's event. Now, it is with great pleasure for me to introduce the next speaker today, who serves as the chairwoman of Women United, Ms. Tawan Stout Mitchell. Many of you may already know her as a former city council member. Ms. Tawan has given much of her life and career in service to the Memphis community. I've had the honor of serving alongside Tawan on Women United's board for the last 2 years. To see her heart for helping women and advocating for others and the less fortunate, it's truly inspiring. She is a driver for many of our Women United initiatives, and she's a mentor to me. For that, I'm eternally grateful. Ladies and gentlemen, please join me in welcoming Ms. Tawan Stout Mitchell.
Thank you, Naika. Good evening. During this COVID-19 pandemic, we have probably felt every emotion there is to feel: confusion, anxiety, depression, loneliness. We've even had the vulnerable feeling of desperation to survive as we grieved our loved ones and friends. But I am so honored to have been a part and a chair of women who not only consider surviving themselves, but reaching across through the power of technology to help others. We gave out over 7,000 masks to homeless shelters. We organized by phone banks and videos, Get Out the Vote campaigns. And we used technology to bring you experts from the national, state, and local levels to give you the information, to empower you with information, to make a critical decision for yourself and your families. I want to thank Dr. Marilyn Robinson for her visionary leadership, because this was really her idea. I'll be honest with you, I said, oh my goodness, not another idea. But we answered the call. I want to thank our experts who gave of themselves, their time, and their expertise to share with all of you. I want to thank Women United, who took week after week phone calls of planning to put together this extraordinary event. I would be remiss if I did not thank our sponsors, the Commercial Appeal, MLK 50, Local 24, and our moderator who did an excellent job in asking probing questions. I want to thank all of you for joining us tonight. And if you have further questions, please check United Way's website. Now, I have the honor of presenting the President and CEO of United Way of the Mid-South, Dr. Kenneth Robinson.
Good evening, everyone. Wow, this has been quite an evening. It's been an evening of good, candid conversation, an evening of tough questions. I really want to thank our audience for being here tonight, but let me start by thanking Women United and Twan Stout Mitchell, and yes, Reverend Marilyn Robinson for conceiving this night. It's been very interesting. As you know, this was postponed 2 weeks ago in the midst of a snowstorm. And even though it was a virtual event, we really had the desire to produce this event in this place so that we could have some face-to-face interaction following social distancing rules and following CDC guidelines. And then tonight, we find ourselves in the midst of the storm, in this case, a storm of a little local controversy. And the reality is that we've never been this way before. We've never been this way before. We've never been this way before. So I really want to thank Dr. Barney Graham, who enlightened us. It was in Dr. Graham's lab, as the chief of the viral pathogenesis lab, that this mRNA technology was first designed, and he worked in the institution of that first Moderna vaccine. Dr. Graham is the real deal. Dr. Graham has a personal story to tell, and he shared his expertise all the way from the NIH with us tonight. I want to thank Dr. Lisa Piercy for joining us this evening. Dr. Piercy, as you know, I used to sit in that seat for one term during a previous governor's administration. I remember how difficult it is working with health departments all across the state. And I particularly empathize with you because I was the commissioner during the first SARS virus pandemic. And I remember the challenges that we faced and being able to respond in a timely and appropriate way to what we thought was going to be a significant assault on the health of Tennesseans. I want to thank Dr. Lisa Haushalter. You've been the woman with all of the attention locally. I think you've done an extraordinary job as the director of our Shelby County Health Department. Thank you for coming tonight in the midst of even the transition of responsibility around the distribution of the vaccine, but yet you are our local public health authority, and we thank you for bringing your expertise here tonight. Thank you, Dr. Boutte. You're on the front lines, and Walgreens will be one of our retail pharmacies that will be helping us with the distribution. Dr. Washington, you are there, and your colleagues are taking care of a population of people that really need you, need your insight, need your empathy in terms of the coexisting conditions that exist in our community and the superimposed risk of this COVID-19 virus. And then we are particularly grateful to have with us Dr. Reverend Keith Norman. He is the triple threat as the pastor, as member of the Memphis-Shelby County COVID-19 Task Force, and as an executive at Baptist Memorial Healthcare Corporation. He understands this holistically, and thank you for your wisdom, for your passion, and certainly, my brother, for the prayers upon this community as we are dealing with the issues that are before us tonight, and then the personal issues that are confronting our parishioners and people in the community, and certainly those that have lost loved ones. We've had an extraordinary moderator tonight, Wendy Thomas. She has challenged our panelists. Wendy, thank you so much for going that extra step and researching the issue before us this evening and driving this conversation. We've never been this way before. I stand before you tonight as the President and CEO of United Way of the Mid-South. I am not the Tennessee Commissioner of Health now. I am not, although I once was the county health officer. I am not the public health policy advisor to the county mayor. I once was. Tonight, I stand before you in this role because this is an issue for us to be a community united. It is the United Way of the Mid-South and Women United that have brought us together tonight because we are standing at the intersection between the faith community, the medical community, our pharmacists as providers of frontline information and vaccines to the public. We're standing at the intersection between the State Department of Health and our local health department, autonomous and independent to some extent from the state. We stand at the intersection between those of us on this stage and you. We really do hope and pray this evening that you have been informed, that you've had your questions answered. We really do hope that you've been inspired and encouraged yourself to consider taking the vaccine. I stand before you as the President and CEO of United Way of the Mid-South because we've got to be united in this fight against this virus. This is not a fight among ourselves. This is a united fight. We must provide a united front to combat this virus in our community. We are not divided tonight. We're learning how to do this. There have been some painful lessons, but we've never been this way before. We are united in our desire to overcome this pandemic. We are united in both our grief for those we've lost, our concern for those that are even tonight dealing with the pain and the pathos and the problems of being infected with COVID-19. We're united in our desire that everyone who is affected by the virus, even those of us who've lost jobs and lost hours and lost income, that all of us can get to a point, not where we were pre-pandemic, but we can get to a good point of restoration and healing after this pandemic. And the only way we're going to get there is to be considerate in our thinking about how we get this vaccine. So tonight, if you don't mind, I'm going to suggest that we are united in wanting to come together across this community, across the divides, political, social, economic, racial, health status. I'm believing that we are united together in understanding that when there is a vaccine available to us, we're going to be, as Dr. Graham said, first in line to take that vaccine. It is not a matter of whether one is better than the other. We're going to be in line to take that vaccine so that we can get past this. I believe that this is why the United Way of the Mid-South has called this panel together. I think this is why all of these experts have given us their time this evening. I'm certain this is why Wendy is here, and a great journalist, provoking, asking, prodding, so that we can have the information we must have to get past this. And if I could wear the other hat that I wore for many, many years as a pastor in this community, I would say, who knoweth whether we have come to this place and come to this time and come with these experts before us for such a time as this. The United Way of the Mid-South, Women United, we have offered you this information tonight. Be encouraged, inspire someone else. Thank you so much for your time. Good evening.